Good morning, and thank you very much for having me today. And so Jack asked me to talk about repeat biopsies and serum-based testing, and I'm going to try and cover some of the serum-based testing that maybe people have heard about and more familiar with, and some of the serum-based testing that we may see coming forward in the future. So when you're thinking about a test and why we order a test, there are two things that we always need to think about. Tests can be done because they'll give us information that's prognostic. And when you think about prognostic information, it's information on the course of your cancer, but it doesn't really matter what treatment you give. And probably the best example that we have in lung cancer right now is KRAS mutations. We know that in patients with early stage disease that if you have a KRAS mutation, you may be at higher risk of relapse or dying from your disease than patients who are KRAS negative. Other test considerations are that it may be predictive, and that a predictive test is something that I think is more useful because it provides a likelihood that you'll respond to therapy in a specific population. And so, for example, we know if patients have an EGFR mutation in their tumor, they're likely to respond to drugs like erlotinib or gefitinib or afatinib. And so keep this in mind as we go back and forth in talking about some of the blood-based testing that's available right now. Now, you already saw this from Dr. Rackham, sort of this evolution of non-small cell lung cancer with different histologies and also different classifications based on adenocarcinoma versus squamous cell carcinoma. And basically, the real progress that we have made is in adenocarcinoma. And it's some of the frustration that we have in clinic where we get someone's molecular testing report back and we find out that they're PIK3CA positive or the tumor is NRAS positive or KRAS, and we can't necessarily do anything about that right now beyond knowing it's there and hoping new drugs will come along. And really the greatest progress we've made was initially in patients with tumors that were EGFR mutation positive, then ALK, now ROS1 has come along, and BRAF positive tumors also have what we think about as targeted therapies. And as time goes by, a bigger portion of this pie will get filled. I have some people say to me, well, where does PD-L1 fit into the molecular testing? It doesn't. It doesn't seem to overlap. It's a completely different test. And we've made progress by knowing what patients' molecular status is as well as histology. 3 decades ago, the average patient with lung cancer had a survival that was less than 1 year. And now we're looking at 2-3 year survivals in specific molecular cohorts, and that's only getting better and better with time. So what testing is currently available for a tumor? You could either do a biopsy of the actual tumor, either the tumor site or a site where the cancer is spread to a metastatic site. It gives you an impression at a very select time point, so when you do the biopsy prior to or after a certain therapy within a very select region of the tumor. And it can be done on the primary tumor if that's accessible, or sometimes if there's a lymph node or somewhere else that's easier to biopsy, we'll biopsy the metastatic site. There's also blood-based testing, and that's starting to get more traction, which gives you an impression at a select time point, but what's nice about blood-based testing, it's easier to do multiple time points. Everyone walks into clinic and just puts out their arm, and if you took an extra tube of blood because you want to do blood-based testing, that seems to us less invasive than having to put someone through a biopsy where we have to stick a needle into an organ. And it may give us an overall indication of the tumor burden, so how much tumor there is within the body, but maybe that we need a critical amount of tumor to be present. So if there is just disease within the lung, are we going to be able to detect that in the blood, or does the cancer have to be somewhere else that we know it's within the bloodstream that we can detect the tumor? And at ASCO this year, we had some very interesting data about urine-based testing, so even less invasive. Maybe we don't have to poke people at all. Not really going to talk about the urine-based testing. The data that came out was only on about 20 patients. So we know that the tumor environment is very complex. And within the tumor, you have the endothelial cell. And the endothelial cell is going to be interacting with the surrounding macrophages, fibroblasts, the extracellular matrix. It'll also be interacting with the immune cells. And what we don't know from a biopsy is, does it matter if the biopsy is done here within the tumor or if the biopsy is done there? There's been some interesting data, not so much in patients who are mutation positive, but in patients who are PD-L1 coming in for PD-L1 trials, where it may determine whether or not you're PD-L1 positive based on where you're actually performing the biopsy. And there was a really interesting slide that was put up at ASCO this year showing a lymph node that was PD-L1 positive at the top of the lymph node, but negative at the bottom of the lymph node, and where you did that biopsy could have determined whether you would have been eligible for a study. That is not the case with mutations. It doesn't seem to be as complex. But why do we want to consider doing a blood-based test rather than poking into different areas? Blood-based testing can help us guide treatment decisions. Sometimes lesions are very difficult to biopsy. There are some times where we are putting people through multiple biopsies in order to get tissue. And wouldn't it be better if we could just do a blood draw rather than 3 biopsies in order to find out the information that we need either to change therapy or for clinical trials? We also know that tumors are very, very heterogeneous, and mutations can change over time. And doing blood-based testing may be an easier way for us to determine these changes with time. Sites that are sometimes amenable to biopsies may not give specimens that are sufficient for molecular testing. PD-L1 testing, for example, can't be done on pleural fluid or fine needle aspirates, so small samples. There have also been times where we've had trials open for patients who are EGFR mutation positive when they're tumors, where we couldn't send pleural fluid in for analysis, even though that was the site where the tumor was growing. And so we had to do more invasive testing. And maybe blood-based testing can get around this problem of what organ or where are you sampling. And the big issue is that biopsies don't always give adequate material. About 10% of patients who get an initial biopsy for their lung cancer will have to have repeat biopsies at our institution when they come to see us because there was not enough tissue on that first specimen for molecular testing. And we always want to have the molecular testing information prior to considering therapies. So what are some of the sources of blood-based biomarkers? The ones that are most evolved in terms of what we're looking at are the DNA, the RNA, and the proteins. The DNA specifically is where we're getting information about patients' mutations, such as EGFR, or rearrangements such as ALK, ROS1, and RET. And there's also been some information looking at different protein levels. The RNA is really something that's being looked at more in early stage kind of detection of cancer, earlier stage. So one of the blood-based testing that I'm going to talk about briefly, just because I feel like it's out there and people seem to know about it and people often ask about it, is the Veristrat testing. And this is a mass spectrometry test that's done on patients, blood-based. It's protein, looking at protein levels of expression, and we get 2 peaks that come out on the read. And based on the peaks, we will get information back that this patient's tumor is Veristrat good or Veristrat poor. Now, what does Veristrat mean right now in terms of blood-based testing? There have been many studies that have looked at this in patients' tumors, and right now the way I sort of think about Veristrat is that it's prognostic. So if you look, VSG is Veristrat good, and VSP is Veristrat poor, and there have been multiple different trials, primarily looking at it with targeted therapy, but some with chemotherapy. And if patients have tumors that are Veristrat good, their overall survival appears to be better than patients who have tumors that are Veristrat poor. Veristrat is also in some ways predictive, and that came out of this trial that was done at the bottom, the PROS trial, which took patients and looked at their Veristrat status. And if patients were Veristrat good, they seemed to actually have tumors that did well when they were treated with erlotinib. And Veristrat was a predictor in that if you're Veristrat poor in your tumor, erlotinib was not a good drug to give, and potentially chemotherapy would give. It's not a test that I order routinely. It's not a test that I would recommend routinely, but it's sometimes a test that I will think about if I'm looking at erlotinib in a patient who does not have an EGFR mutation, and I'm trying to think about erlotinib versus chemotherapy. If the tumor comes back as Veristrat poor, I know chemotherapy is going to be a better option. moving from looking at proteins to looking at circulating free DNA. And the circulating free DNA, we know that tumors shed, and the circulating free DNA is where a lot of the excitement and research is currently being done at lung cancer, looking at can we replace tumor biopsies with blood-based testing, either looking at specific mutations. And part of the reason that we want to do this is because we know that tumors can change over time. And last year at one of the meetings, there was a poster that was put up that looked at patients' tumors and compared tumor results to blood-based results, looking specifically at next-generation sequencing. Now, next-generation sequencing is that big test that patients are sometimes getting back. Foundation of Medicine is one of the places that does it, where we look at 300 different genes, and you'll get a report out saying that the tumor expresses these specific genes. The next generation sequencing, similar to that pie chart, gives an even bigger pie chart, but often with information that I personally don't think is super useful unless it can actually tell me about a targeted therapy that I would be able to use or maybe lead towards a clinical trial. But what this study did show us is that if you looked at the concordance between the biopsy and blood-based testing being done at the same time, the concordance is 93%. But 6 months later, that drops down to 67%. And that's because in that 6-month period, patients have had treatment. And we know that the tumor changes with time. And potentially the blood-based test is giving us better information at a later point in time than when you compare a blood-based test to a biopsy that's several months old. There are multiple different technologies and platforms that are looking at circulating free DNA. And depending on the platform, depends on how much information that you get back. So you may go back down just getting one test, such as knowing if you're EGFR positive, if your tumor has a sensitizing mutation, or if you're T790M positive, all the way down to a panel that has 68 genes. Again, these genes may not always be the most useful genes to know about, whereas knowing about something like EGFR or BRAF would be more clinically relevant and clinically applicable. You'll notice that some of these panels do not have ROS1 or RET fusions, and that's because if you're not doing next-generation sequencing, such as being done in this panel, to do the ROS1 and RET fusion tests, you're either going to do it on tissue by a IHC, so immunohistochemistry, where you stay in the tissue and look under to see how brown the cells are, or you're going to do it by the FISH testing. And some of these blood-based testing are not tumors that you can do FISH or IHC on at this time. When you look at the different tests, they've also looked at how sensitive these tests are and the concordance between the tissue as well as the blood-based testing. And this has been done on multiple different samples from large clinical trials like the IPASS, which was a trial in Asia that compared chemotherapy to gefitinib in patients who were never smokers but not necessarily EGFR positive. Not really highly sensitive, but very specific. And the sensitivity and specificity varies. Now, what's the difference between knowing is something sensitive versus specific? Is something specific that can help you rule things out. Something that has a high sensitivity, specific helps you rule things in. Something that's very sensitive can help you rule something out. So if a test has a low sensitivity, having a negative test does not necessarily definitively rule something out for you. And this is just more examples of testing that was done specifically in patients who are EGFR positive, looking at the sensitivity and specificity of different plasma-based testing, looking for EGFR. And these numbers, I'm specifically going to talk about this study, showing maybe slightly higher sensitivity. And this is just we always want to know how well does tumors correspond with circulating free DNA. And this is data just from one study, the IPASS trial that I mentioned, where they looked at how well does the concordance. So, part of it was, so what if the tissue matches the blood? More importantly, does it help predict if people are going to do well from the treatment that we give? And so this is data from the IPASS that specifically looked if the tumor was EGFR positive, patients had about a 70% chance of responding to EGFR therapy if both the tumor and the plasma were positive. So if both tests were positive, the response to therapy went up almost 80% or 82% if deletion 19 was the assay, and if then the tumor was positive, but the plasma was negative, the response rate went down. So this has been looked at. This was looked at retrospectively, but can this help us figure out, should we continue to do tissue biopsies, or is one tissue biopsy enough? But if there's not there, if we can analyze the circulating free DNA, will we get enough information? We all know that EGFR inhibitors are wonderful drugs, but the problem is that these drugs change with time. And this was a slide that I borrowed from Dr. Tony Mock, who shows us how that when you're on an EGFR inhibitor, you can have different models of resistance. And probably the simplest model is this first one, where the tumor is fairly heterogeneous to begin with. You go on your EGFR inhibitor, and the tumor evolves over time to become T790M positive. And with time, the tumor first shrinks but then regrows, and so we have to switch therapy to, say, a third-generation inhibitor where the tumor shrinks and regrows but has a new mechanism of resistance. It would be nice if tumors were this simple, but we know that the tumor starts off complex. And there may even be a few cells to begin with that are inherently resistant and have T790M. And so with time, on the first EGFR inhibitor, we'll see the tumor shrink, but a dominant mechanism of resistance will evolve, such as T790M. We'll then switch to a third-generation inhibitor, and that dominant mechanism will go down, the red goes down, but now we have a new mechanism of acquired resistance. And it just shows how complex that tumor is, and depending on where you biopsy, you may or may not find that new mechanism of acquired resistance. This was looked at in the Tiger-X trial. The Tiger-X trial is a trial that looks at ruxolitinib in EGFR-positive patients. And Dr. Sequist at ASCO this year tried to look at the correlation between tumor and tissue. And so on this chart, here's tissue, and here's tissue positive and tumor positive. So 155 patients had both tissue that was positive and tumor that was positive, which gives us about a predictive value of about 81%. But there were some patients whose tumors were negative, but their plasma was positive. And there were some patients whose plasma was negative, but their tissue was positive. And how that works in terms of response rate, we can see that if patients had plasma that was positive and tumor that was positive, they had a 55% chance of responding to ruxolitinib. If their tissue was positive at all, they had a 53% chance, or if their plasma was positive at all, it was about a 53% chance. But there are patients who have tissue that is negative, but plasma that is positive, and about a third of those patients were still responding to ruxolitinib. And if we relied specifically on the tissue test here, we may not have given those patients a third-generation inhibitor. And similarly here, we'll have patients whose tissue are positive and plasma who have negative, and traditionally, those are the patients who we have enrolled on study because we have a good tissue diagnosis confirming resistance, and the response rate was 43%. What you can see as well is there's some patients who are negative on both, but still 25% of people are going to benefit from therapy. So it's still complicated. We still don't know which is the best plasma-based test to use, and we're still trying to figure all of this out in studies that are ongoing. So at this time, we know that testing for tumor in circulating DNA is available. It's there for both diagnosis and monitoring for emergence of resistance. There are different technologies that are available that we can use to isolate and analyze the circulating free DNA, and I don't know which one is the best one. There are large studies that are going on to determine how well tissue and tumor, from tumor and blood are concordant. The studies are looking for emergence of acquired resistance with select therapies, but we don't know what the value of detecting acquired resistance in blood prior to seeing growth on a CT scan is. And at this time, I would argue that there is not great value there in switching therapy just because we may detect it in blood. Many of the technologies that have been used to date have very similar performance. And what really matters right now is using the right test at the right time. So large panels with actionable mutations upfront to look for things like BRAF, EGFR, ROS1, RET, and ALK, and more focused surveillance in patients with known mutations on targeted therapy. For example, if you are on an EGFR inhibitor, looking for something like T790M, where we know that we have effective second-line therapies or that hopefully will soon get approval of clinical trials. We also want to make sure that we have results in time to guide therapeutic decisions. Molecular testing turnaround can be anywhere from 5 to 10 days, and we need to have that information relatively fast so that we can make decisions. We also want results that are clinically meaningful, and as I mentioned, I don't know that it's relevant to know that there is acquired resistant presence in the tumor if the tumor still appears to be under good control on the scan. And of course, it all comes down to cost and how easy the tests are to obtain. Thank you.